Good afternoon. It's my pleasure to be here, and I really appreciate the invitation. Well, these are my disclosures, but the industry had no involvement in the development of this study. Well, when we designed initially this trial, we have previously performed a preliminary study that the main result was that we observed a different role of high-flow conditioned oxygen therapy for the prevention of post-extubation respiratory failure and reintubation according to the risk of reintubation of patients. So we decided to perform two parallel trials. One focused on patients without any of the preselected high-risk factors for reintubation, and this study was published a few months ago in JAMA. We here randomized high-flow conditioned oxygen therapy against conventional oxygen therapy, and we obtained a significant reduction in the reintubation rate. And well, now this is the second part of the study that's now accepted for publication. This part is somehow different. We have included here patients with at least one of the high-risk factors for reintubation, and we consider that well, patients at high risk for reintubation could benefit from the use of NIV. There is no strong evidence for that, but well, there is evidence, and there are an important international survey study that reports that NIV for this indication is used around the world close to 10% in the patients. So we decided to compare high-flow oxygen therapy to NIV. And, well, under this situation, we did not expect at any time that high-flow could be superior to NIV. And we decided to perform a non-inferiority study. We have used from the beginning that we use this therapy, the same protocol. This includes, when indicated as a preventive option, like is the case of this study, we use for a fixed period of 24 hours, and the same for MIV in this study. And we always set the flow according to the patient's tolerance. Well, we finally included patients in 3 Spanish intensive care units. The sample size was estimated based on previous data on reintubation rate according to the use of both therapies, and that was 600 patients. Well, we designed a non-inferiority study, and we chose a margin of non-inferiority on 10%, and this is mainly because of what I have said previously, the rate of use of NIV in these situations, because there is no strong evidence for this NIV in these patients. And we decided to perform a unilateral 95% confidence interval non-inferiority analysis. Well, we use the reintubation rate, the primary outcome, as the same for post-extubation respiratory failure, but estimated the sample size according to reintubation rate. As post-extubation rate is expected to be higher than reintubation rate in this population, we concluded that it will be powered enough to consider post-extubation respiratory failure as another primary outcome. And, well, the secondary outcomes included respiratory infection episodes, length of stay in both ICU and the hospital, mortality, adverse events, including patients needing to do withdrawal of the therapy because of discomfort or any other reason. And as a safety surrogate, we analyzed the time to reintubation. So, well, the most important point for designing this protocol was to choose which of the high-risk factors could be included in this study. There is no validated model for this, so we decided to use the high-risk factors included in 2 previous trials analyzing MIV for the same indication in high-risk patients. This is one of the 2 trials, including age, cardiac failure, the reason for their intubation, the PACE-2 score, the day of extubation, and the second study included some other high-risk factors like difficult or prolonged weaning, hypercapnic COPD patients who develop hypercapnia after extubation, not before, patients with more than one comorbidity, and so on. So we finally This is the flow chart of a study. We finally screened more than 5,000 patients. We included patients under mechanical ventilation for more than 12 hours, just to exclude patients under NIV for short periods after scheduled surgical interventions. And well, the most important exclusion criteria were patients without any of the high-risk factors selected in the design, patients with not reintubate orders and scheduled extubation, or those who develop hypercapnia during the spontaneous breathing trial, because at the time we designed this study, there was some stronger evidence for a benefit using NIV in this specific group of patients. So we finally randomized the estimated sample size of 600 patients. Fortunately, we really list a low number of patients, so the intention to treat and per protocol analysis were quite similar. This is the table 1 of the study. Just want to point out some specific details. The length of mechanical ventilation in both groups was similar, in a median time of 4 days. And well, according to the risk factors that patients had at the inclusion moment, there was no statistical difference. But well, some comments raise a concern about a possible disbalance between the inclusion of patients with heart failure as the primary reason for intubation. So we performed a specific analysis that excluded finally any modification in the main conclusion secondary to this possible disbalance. Another point that I want to remark is that we obtained a mean number of high-risk factors in both groups, 3. That's higher than previously reported in many other previous studies. So I consider that this is a design with 10 high-risk factors. That's a lot, obviously, but patients had 3. I mean, they are really at high-risk factors for high risk for reintubation. Well, according to the diagnosis at admission, we, as expected, obtained a lower number of patients included after a surgical intervention, or even patients with a neurological diagnosis at admission, or, well, that could be considered neurocritically ill patients, including neurosurgical intervention or trauma, brain injury, or neurological primary disease as the reason for admission in the ICU. So with this in mind, we analyzed the results. And the primary outcome was all-cause reintubation, and we obtained a 23% reintubation rate in the high-flow conditioned group, compared to 19% in the NIV group. And well, to fulfill the criteria to define non-inferiority, when you use a unilateral 95% confidence interval method, you can confirm non-inferiority if the lower side of the unilateral analysis is lower than the pre-specified boundary. So it has to be lower than 10%. This is 9. So, well, we confirm that in terms of all-cause reintubation, high flow is non-inferior to NIV. And the same for the other primary outcome, that is post-extubation respiratory failure. We obtained 27% in the group of high flow therapy, and 40%, that's unexpectedly high, in the group of NIV. Obviously, this is non-inferior, but if we performed a conventional superiority analysis, and the result confirmed that, well, we could consider that NIV in this study was associated with a significant increase in the post-extubation respiratory failure rate. I'll comment this later. Well, according to the secondary outcomes, there was no significant difference in anyone except the length of hospital stay. That there was a reduction in 3 days, and the statistical analysis confirmed the significance of this result. Well, we also analyzed mechanisms of both post-extubation respiratory failure and reintubation. In the first case, the post-extubation respiratory failure, there was no statistically differences in any case, but, well, from a clinical point of view, I consider that there is in the case of inability to deal with respiratory secretions, a reduction in the number of patients with post-extubation respiratory failure secondary to this reason. But I insist that there is no statistical analysis confirming this. That's just a clinical interpretation. And for the case of reintubation, it's the same. There's a reduction in the number of patients reintubated because of respiratory secretions management, but there is no difference in patients reintubated because of any other reason, including hypoxemia or hypercapnia. There is a low number of patients reintubated because of a non-respiratory reason, as expected in a high-risk population. But however, as we did with the first study, the low risk, we perform an exploratory analysis, including only patients reintubated because of a respiratory reason, while in this case, the non-inferiority is confirmed with better numbers. Well, we analyze also some physiologic variables. I just will mention two of them. First one is that, and this was also unexpected, the oxygen concentration needed 12 hours after the extubation was significantly lower in the case of the high flow group compared to the NIV. That was 40% compared to 35%. And the gas flow that patients tolerated 12 hours after the extubation was 50 liters per minute. And this is remarkably higher than the flow tolerated in the low-risk study, that was 30 liters. In my opinion, this suggests that, well, when you set the flow according to patient's tolerance, this is the flow tolerated by patients is a marker of severity. This is the Kaplan-Meier curve. This, I just want to say that, well, it's the same line for both therapies, and this sudden increase a few hours after the high flow is switched off and patient is under conventional oxygen therapy after 24 hours. There is an increase in the reintubation rate. That, in my opinion also, this probably suggests that the optimal time under high flow for this indication could probably be improved to more than 24 hours. So the performance of this therapy could increase with a more prolonged time. This is the survival curve. There is no any difference. And well, according to safety, when we use an intermediate therapy support, there is always the concern that you can delay the increasing in the to the optimal therapy. In this case, could be orotracheal intubation. The surrogate for this safety was used as the time to reintubation, and there was no difference. Even more, it was higher in the high flow group. That was well, probably the reason for that is explained with this other variable, that the presence of adverse events is really significantly higher in the NIV group. This is mainly secondary to discomfort, motivating withdrawal of NIV in many patients, as the length of the median length of NIV in this study was 14 hours from the initial 24 per protocol. And this is secondary to discomfort. Mainly, this can be the reason for, well, a shorter time to reintubation and even an significantly increased rate of developing post-extubation respiratory failure. Well, in my opinion, the two most important limitations of this study was obviously it could not be blinded, and that's a fact. And the other one is that, well, there is no validated model for using specific high-risk factors for reintubation. So we analyze patients included in the trial only with one high-risk factors, and the main conclusion was not modified. So, well, I think that there is no a risk for inclusion of low-risk patients in this study. So, well, to conclude, I say that high-flow conditioned oxygen therapy through a nasal cannula is non-inferior to NIV after extubation in high-risk patients. In terms of reintubation rate, high-flow seems to be superior to NIV after extubation in this kind of patients in terms of post-extubation respiratory failure, mainly secondary to discomfort in many patients. high flow reduces hospital length of stay and, well, is safer in this subset of patients compared to MIV. So, well, thank you. I want to thank all my colleagues for the collaboration in this trial, and thank you all of you.